Integrating global health into our science and engineering curriculum has the potential to not only train the next generation of students to tackle challenges in global health, but it also draws and keeps a diverse set of people at the table. To illustrate what I mean, I want to take you back in time and tell you a little bit about my own journey through engineering. This was me in 2005 as a freshman at Rice University. I had chosen bioengineering as my major because I thought I would love it and could impact the world. But my freshman year, I started feeling disconnected. I didn't really understand why I was taking all of these math and science classes. It was like I was learning the notes on the piano, but I couldn't figure out how they went together to create a piece of music. So I began to question if bioengineering was really for me. And that question was answered in an unexpected way by a professor named Dr. Rebecca Richards-Cordham, who came to my Intro to Engineering class to tell us about a curriculum she was developing called Global Health Technologies. The idea of the program was that we were going to take the skills we were learning in bioengineering and apply them to develop medical tools for low-resource settings. Her name might sound familiar because she just won the MacArthur Genius Grant for her work with undergraduate students in global health. So she definitely knew what she was doing with me. So I signed up for her classes, and not long after had the opportunity to travel to the country of Lesotho to do an internship. One of the lessons that we were learning in the classroom is that there are huge disparities in health around the world. But I don't think I fully appreciated this until I saw it firsthand. This is what I was used to seeing, the Texas Medical Center across the street from Rice University. And this is what I saw in Lesotho. This is a pile of broken beds that I photographed outside of the main entrance to the Queen Elizabeth II Hospital in Maseru. And this is one of the most advanced and comprehensive facilities in the entire country. As you travel into rural villages, remote clinics have even fewer resources in terms of both trained personnel and medical equipment and supplies. And most of the Sesotho people live in these rural communities and have a really hard time accessing clinics and hospitals. To combat this problem, we had started working on a project called Lab in a Backpack, which is essentially a backpack full of medical equipment that physicians can take with them to provide care in rural communities. I had worked on designing the central power unit that powers all the different pieces of diagnostic devices in the pack and can be recharged with solar energy when physicians are in the field. We took the pack to this really remote clinic in the middle of the mountains and left it there for physicians to use and provide feedback about its design. Since I left Rice, this project has grown exponentially, primarily due to recognition from the Clinton Global Initiative and through partnering with the Ministry of Health in Ecuador. Now, over 10,000 patients have been helped by this technology. During my time in Lesotho, what really struck me is how few resources physicians had to work with in these places where most of the people lived. So I wondered, what can I do about this? But I had no idea how to answer that question. So I sat down with Rebecca, and she told me something I will never forget. She said, to solve global health challenges, you have to bring some sort of expertise to the table. It's like a highway with very few on-ramps, but lots of exits. To stay on the highway, pursue a PhD in biomedical engineering, and then when you see the exit you want, take it. So I followed her advice. And now I'm working with Dr. Nimi Ramanujam and her Center for Global Women's Health Technologies here at Duke, which serves as a bridge between the Pratt School of Engineering and the Duke Global Health Institute. At the center, we leverage our expertise in technology to make contributions in women's health, education, and empowerment. As part of my work with the center, I've had the opportunity to help develop a class called Women's Health Technologies, which, by the way, is open to any Duke undergraduate, regardless of major. In the class, we talk about global poverty and the consequences that it has on women. And through laboratory components, we teach students the human-centered design process, and they apply it to build solutions for real clients, often in locations where they're traveling to the following summer through a program called Duke Engage. What's been really remarkable about this class is that our engineering classroom has started to look and feel a lot like the global health classes I took while I was a graduate student at Duke. Essentially, the diversity among students leads to powerful discussions about poverty and the role that technology can play. In the class, what's really interesting is we end up talking so much about the reproductive system because it's responsible for so much of women's health. Anything from violence and global mental health, which you heard about this morning, to infectious disease, to cancer, to maternal fetal health. And in particular at the center, we're really interested on developing technologies that can be used to combat cervical cancer. We have the tools to combat cervical cancer today, but that was not the case 60 years ago. This is a photo of Henrietta Lacks, who has since become a very important historical figure. Her cervical cancer cells were immortalized and have revolutionized medical research since her death. But what I want to point out is that she was only 31 years old when she died from cervical cancer. We now have the technologies to combat this problem, due largely in part to inventions from George Papanicolaou, who developed the Pap smear that's now widely used to screen women for cervical cancer, and Hans Hinzelmann, who developed the colposcope, which is now used as the gold standard device to confirm disease in women who have abnormal Pap smears. But the real irony is that the untimely death of Henrietta Lacks is still relived time and time again in many low-income countries around the world today. In fact, the ratio of cervical cancer deaths in low-income countries compared to high-income countries was threefold higher in 1990, fivefold higher in 2010, and is predicted to be 9 times higher in 2030. And this inequality still exists right here in North Carolina. If you travel out to the rural communities, cervical cancer rates look very similar to low-income countries. So why is this still a problem if we have the technology to address this? And the issue is that women cannot access the technology or the physicians who are trained in colposcopy to diagnose cervical cancer. This colposcope right here costs $20,000 and weighs over 150 pounds. A low-resource clinic cannot afford it. So we asked the question, what if we could bring colposcopy to these low-resource clinics at a fraction of the cost? So our idea was to take the colposcope and move it up closer to the cervix, about 1 inch away, like they do in transvaginal ultrasound. And by doing that, we could get rid of the expensive optical components that you need to view the cervix from a foot away, and rather replace them with consumer products at the tip of the probe. And so we developed what we call our point-of-care tampon or pocket colposcope. It costs $500, weighs 1 to 2 pounds, and you can plug it in to a laptop or smartphone to view, capture, and send images to physicians. Right now, we wanted to ask the question, do we actually get comparable image quality with this device compared to that $20,000 device? And so I wanted to show you these 2 sets of images and ask you, which one do you think was captured with our device? This is the correct answer. If you got it wrong, don't feel bad, because it turns out physicians can't really tell the difference either. In fact, physician interpretation agrees over 90% of the time between these 2 devices. Right now, we're working with a company called Thirdstone Design and the Office of Licensing and Ventures here at Duke to optimize the form factor of this design and to commercialize it. And what this truly represents to me is the power of human-centered design applied to solve a global health challenge. But this is just one example. There are so many examples out there that could be solved with innovative solutions. And so we need you as engineers, scientists, social scientists, and medical professionals to help us understand what the problems are and to identify solutions. There was a time when I might have left biomedical engineering, but today it's keeping me and countless others through integrating global health into its curriculum and research. Thank you.